Hello friends, today we are going to talk about the pathophysiology of coronavirus. See, this video is purely for educational purpose and there is a medical disclaimer associated with it. I do not recommend anyone to watch this video for any diagnostic, self-diagnostic purpose. This is purely for students for educational purpose. Okay, let's get started. See, coronavirus is creating havoc all around the world. It has become pandemic and so many countries are struggling to fight with this deadly pandemic. And you know, the virus associated with this is a coronavirus, typically a virus which is an RNA virus, single-stranded positive RNA virus, and it has got spikes all around. Now this virus enters into the body through two routes. One is the respiratory route and another is the fecal-oral route. The respiratory route is through contact to the mucous membrane, typically the T-zone of the face, the eyes, the nose and the mouth mucous membrane. When this virus comes in contact with, it enters into the respiratory system, and therefore we recommend everyone not to touch their T-zone when they are out or when they have come contact with any person who is having cough or sneezing. Right. So this coronavirus typically enters into the body through the respiratory droplets. It comes in contact when the virus comes in contact with the surface. At that time someone touches that surface and touches the T-zone, typically T-zone of the face, it enters into the respiratory tract. Apart from that, there is one more, and that is fecal-oral. Say for example, someone is suffering with coronavirus infection and he goes for stool and then he washes his bottom with his hand and does not wash his hand properly, and then he touches any surface or for that matter handle of the toilet, and then other person who comes in contact with that handle or the toilet contaminates his hand, and then that fellow, if he touches his T-zone, the mucous membrane of this eyes, nose or the mouth, he may contact this virus or he may get inoculated with this virus. So two ways, one is respiratory and another is fecal-oral. Now, once this virus, which you can see here, is typically a round one, right? And it creates a halo around it, and therefore it's like sun halo, and hence referred as corona. This has got spikes, and one of the important spike is this S spike. When this enters into our respiratory system by defeating the immune system, by defeating again various defenses. For example, there are plenty of defenses, starting right from the nose, the zigzag pathway, the VBC, and so many. After defeating that, once they enter into the respiratory system, they attack the alveoli. Once they attack the alveoli, they come and get bind with the type 2 pneumocytes. Now, we have to understand here, in an alveoli, there are near about 90% of type 1 alveoli. You can see here plenty of type 1 alveoli, whereas in between there are 10% type 2 alveoli. Now, these are type 2 alveoli. We have to understand that this type 1 alveoli's function is the gaseous exchange. The air which we inhale, the oxygen which we inhale, that enters into the capillaries through this respiratory membrane, and that work is being done by type 1. Whereas this type 2 alveolar cells or type 2 pneumocytes, you can call them as well, the function is to secrete surfactant. This surfactant is really important. This surfactant decreases the surface tension, as we will see further, and then they are really important in preventing alveolar collapse. But come again back to this virus. This virus, as it enters into the respiratory tract, it attacks the alveoli and binds with these type 2 cells. Because on this type 2 cell, there is present a specific receptor for this coronavirus called as ACE2, angiotensin converting enzyme type 2 receptor. This is specific for coronavirus. Once the coronavirus enters into the alveoli, it binds with it. Now, you can see here, this is coronavirus, and the S spikes helps to bind with it. Once it binds with this cell, it enters inside the cell, inside the type 2 pneumocyte, and then what it does, it hijacks the machinery of the host cell. You know, viruses are very notorious for using the host cell machinery. They are obligate parasite, as you know. Now, once they enter into the type 2 pneumocyte, what do? They hijack the ribosomes. They hijack the ribosome and they uses the mRNA of this cell, and they start producing many proteins. So these are again all that proteins that are produced. Apart from that, what also it does, it activates one enzyme called as RNA dependent RNA polymerase, and this is responsible for forming many copies of RNA. So we now have the components formed, and we have now many RNA forms. Together, this protein component and this RNA, they form many baby viruses. Because in a virus, you know, again, there is RNA and then there is that capsid and that covering along with the spikes. Now these covering, capsid and spikes are formed by the ribosome mRNA, whereas RNA dependent RNA polymerase enzyme is responsible for forming many RNAs. So together they form many baby viruses, and these baby viruses then attack the other cells. Now in doing this, what does the virus do is it destroys the type 2 pneumocyte. And it destroys the type 2 pneumocyte and then starts a series of reactions. The type 2 pneumocyte, as they are destroyed, they begin to secrete certain chemicals that activate the alveolar macrophages. Now see, these are the alveolar macrophages that are being activated by these chemicals. Once the macrophages are activated, they releases many chemicals, and out of that, now the important one are interleukin 1, interleukin 6 and tumor necrosis factor alpha. These three are the real actors now. Interleukin 1, interleukin 6 and tumor necrosis factor alpha, they bring on many changes. They are responsible, they get traveled through this very thin respiratory membrane into this capillary endothelium, and what it does is it causes the capillary smooth muscle to contract. It also causes the capillary endothelial cells to contract and thus responsible for widening of the gap between the two cells. This in turn allows the water from the plasma to enter into the interstitial space. Once the water enters into the interstitial space, then what is hampered is the gases exchange. The water enters into the interstitial space, and this water puts pressure on the alveoli. It puts pressure on the alveoli and thus does not allow it to inflate properly. Now coming to that surfactant, what we talked initially, that the type 2 pneumocytes secretes surfactant. See, what does that surfactant do? That surfactant reduces the surface tension. Let's talk about this alveoli. These are again the alveolar cells, and these alveolar cells are lined by an alveolar fluid, and the molecules of the fluid, they exert pressure over each other and thus try to collapse the alveoli. This surfactant reduces this force of attraction and thus prevents the alveoli from collapsing. But now, because these type 2 pneumocytes are being destroyed, the surfactant is also drowned out. The surfactant is also reduced, and above all, the interstitial space is occupied by the water. And that puts pressures on the alveoli and compresses it. When it is being compressed and in the absence of surfactant, they collapses more. The water even enters inside the water enters inside, and that leads to edema. That leads to pulmonary edema, and that hampers even more the exchange between the gases. That is, the oxygen now starts getting less. That is what we referred as hypoxemia. And then there will be the effect of hypoxemia will be seen. At the same time, there will be inflow of some neutrophils at the site from the blood. These neutrophils, they are responsible for causing death of the viruses. Few viruses might die because the neutrophils will secrete oxygen dependent chemicals, and they also secrete certain proteinases. They may kill few of the viruses, but in the process will also kill some other cells, some other alveolar cells. So now the debris of the alveolar cells will slough out. Apart from that, there will be fluid, the chemical mediators, and all these cells, they together will lead to consolidation. So this consolidation is going on. Now, this interleukin 1, interleukin 6 and tumor necrosis factor, when they are in abundance, they will enter into the blood. They will enter into the blood, and then they will be taken to the hypothalamus. Once they are taken to the hypothalamus, what they will do is they will try to regulate the thermostat one more time. The hypothalamus will secrete prostaglandin E2, and that is responsible for the fever. Remember, in this COVID-19 infection, the fever is one of the important symptoms. And the fever is not just 99, it is 104 and above. So we talk about fever. Before that, now, because there is decreased gases exchange, and because there is pressure by this interstitial fluid, and because there is collapsing of the alveoli, there also will be increased work of breathing, what we call that as dyspnea. Shortness of breath will be seen. The patient will not able to complete the statement, he will not able to walk properly, and then there will be dyspnea. So we talk about dyspnea, we talk about fever. Before that, again, there will be cough as well. This cough initially will be dry, but later on, because of all of these secretions, it will become productive. So these are the three very important features of this COVID-19. Let's move further. As this local inflammation becomes severe, the systemic inflammation sets in. And that systemic inflammation will also result into some other features. But at the same time, in the blood, the PO2, partial oxygen pressure, is falling. And because this partial oxygen pressure is falling, the chemoreceptors which are present in the carotid sinus, they will get stimulated. And they will send message to the brain, and then that will cause the water to move out. There will be leaking into the capillaries of the water, and that will result into hypotension, right? At the same time, whenever this carotid chemoreceptors will send message to the brain, there will be stimulation of sympathetic nervous system, and that will try to increase the heart rate. That will try to increase the respiratory rate, and hence you will come across tachycardia and you will come across tachypnea. We talk about fever, we talk about dyspnea, cough, and now the effect of viruses, the tachycardia and tachypnea will be seen. This progresses further and it reaches again the liver. As it reaches the liver, there will be destruction of the liver cell as well. And the liver will start secreting certain enzymes. Now these enzymes will start being getting secreted. What is also important is the liver will start certain more inflammatory enzymes. For example, CRP. This is important. Fibrinogen. This will be secreted, and then they will cause their own set of problems. Also, interleukin 6 will be secreted by the liver. As this proceeds further, there will be hypoperfusion because of the kidney because of the hypotension, and that causes the kidney to react. The kidney will react by its own way. There will be increase in blood urea nitrogen, and there will be increase in the creatinine because the kidney is being hypoperfused and the kidney is unable to excrete this thing. So you come across increased BUN and increased creatinine. Before that, we talk about liver. We talk about again effect on hypothalamus resulting into fever and likewise. Now let's go further. How do we diagnose this? We diagnose this with the help of CBC. We diagnose with help of certain enzymes, and there is again an array of tests we can carry out. In the blood, you will come across deficient lymphocytes. Lymphopenia will be important. Apart from that, there will be effect on the kidney. The blood urea nitrogen and the serum creatinine would be raised. Effect will be seen also on liver. There will be raised ALT and there will be raised AST. Apart from that, when we talk about pneumonia, there is one important parameter that you can see, and that is procalcitonin. Apart from that, there are certain other general markers you can see. C-reactive protein will be increased, ESR will be increased, interleukin will be increased, D-dimer test is really important, and serum ferritin, that is also affected. Coming to more specific, again, nasopharyngeal swab. This helps to distinguish it from influenza. This also helps to diagnose this disease. You can also carry out again real-time polychromatic chain reaction. That also helps to reach the diagnosis. Chest X-ray is really important. And in this, you will come across the ground glass appearance. The ground glass appearance will be seen bilaterally, and that is also important. Chest X-ray is more sensitive, not specific though. You will come across certain things. For example, you will come across the consolidation on the chest X-ray. You will come across the pulmonary edema to be found in the form of ground glass appearance again, and then on the chest X-ray you will come across crazy pavers pattern. You know, when we walk on the pavements are typically arranged properly. Sometimes they are haphazardly arranged. This pattern of pavement is called as crazy pavement pattern, and that is being seen in most of the pneumonias, and COVID-19 is also one of important in that. And finally, USG is also important. In USG chest you will come across the pleural line and again the B lines. These are really important to make diagnosis. So the patient, apart from this diagnosis, the symptoms of the patient is really important. Cough, there will be fever, there will be dyspnea, there will be fatigue, there will be loss of taste and loss of smell. These are being found to be the telltale sign in this COVID-19, ageusia and anosmia. So collective, this is really important. Apart from that, the patient giving you history that yes, I had traveled out where I come across some patients or people who were having these symptoms. So this is all about the pathophysiology of coronavirus. Once you know the pathophysiology, once you understand the disease, it really helps you to treat the disease confidently. Thank you.